utilized for quantitative assay, but that method is completely different. The method is completely different. Do you think the protein solution can answer Benedict test? Anyone? Can a protein solution answer Benedict test? If you can recall, many of you during this practical examination have reported glucose or carbohydrate, but less amount, green color, orange color, but not brick red. And you lost your marks because it was protein which was given, but you tested positive for Benedict test. Many of you did this mistake. What went wrong? The test is so specific for carbohydrate. If the protein is a glycoprotein, it will answer positive. Now, as a matter of fact, human serum albumin is a simple protein. That means it has no carbohydrate. Whereas the protein solution what we provide you for identification is egg albumin or ovoalbumin. So, egg albumin is a glycoprotein. So, if the protein concentration is high, which was supposed to be given less than 1% or not more than 1%, then it will answer false positive Benedict test. And that is what happened. In order to give you more thick precipitate with protein, they added more amount of egg white in the solution. So, in addition to getting protein, you also got false positive Benedict test. This was not your mistake. This was a mistake by the technician who prepared the solution. But few teachers did not consult me before marking, so few of you might get victimized. Doesn't matter, this marks is not going to be added in the final, don't worry. So, now you know what is happening. For every test, there lies a background knowledge in biochemistry. You should be very clear about it. If you know the theory, you can do the practical. You can just predict the test if you are very sound with theory. It's very easy. So, just make yourself so strong in theory that practical becomes very easy to interpret. Now, slowly we will go to the clinical part. We will come with the clinical reports, laboratory reports, and we will go for interpretation. So, if you do not know the basic underlying theory of the biochemistry or metabolic pathways and everything, you cannot relate those tests with the disease concerned. You will be misled like this. Did you know the protein will also answer Benedict test? Your common sense says no, but yes, it answers if it is a glycoprotein. Most of the protein is glycoprotein except human serum albumin. Correct? Now, so similarly, vitamin C, which is a carbohydrate, if consumed more, it will be excreted through urine. So, it will give a false positive Benedict test. Clear? Now, this has got a name called ascorbic acid or ascorbate. It has two forms, one is ascorbate, another is dihydroascorbate. One is oxidized form, another is reduced form. Ascorbate and dihydroascorbate. What is the difference? There is a double bond here and there is no double bond. Correct? These two hydrogens have been taken. That means this is oxidized form and this is reduced form. Fine. So, interconversion between these two will consume what? Hydrogen ion. So, in reactions wherever they need to withdraw hydrogen, we will give this one and we will get this one, right. So, we will see where we require those hydrogens. You will be surprised that it was isolated before TCA cycle was actually elucidated. Same person, Albert St. George. Now, sources. Whatever you take, vegetables, fruits, it should be fresh. And number one. Number two, cooking is a dangerous process to get vitamin C. You destroy it. 90% of vitamin C is destroyed when you cook beyond 70 degrees Celsius. And at what temperature do we cook? 300 degrees Celsius, begun bhaja. Boiling oil is 300 degrees Celsius. So, there is no question we get any vitamin C after cooking. Clear? Whatever it is. So, if we want to get vitamin C, we should take raw, fresh fruits. If the lemon, lemon is full of vitamin C, but if you keep the lemon for many days, it will lose most of vitamin C. It will be still sour, but vitamin C is not sour in taste. What is the taste of glucose? What is the taste of glucose, last bench? Huh? Sweet. Last bench? What is the taste of glucose? Very well. Sweet. If I say it is not sweet, how many of you agree? Stand up. Then what it is? Tasteless. It is cold. Try it. Buy a Glucon-D, take a spoon inside your mouth. What do you feel? Do you feel sweet? No. You feel cold. It is not tasty. Correct? Unless it is a disaccharide, it is not. Fructose is sweet, being monosaccharide. Lactose is sweet to some extent. Maltose is very sweet. Sucrose is sweetest. So, glucose is not sweet. Similarly, ascorbic acid is not sour. The sourness of the lemon is not due to ascorbic acid. What is the next better source for vitamin C? Green chilies. Is it sour? So, now you can make out that vitamin C is not sour in taste, because I doubt if anyone would agree any chili is sour or sweet in taste. Never. Correct? So, the two best sources are lemons and green chili. Do you have it every day? Try having every day. Get the fresh one and have it. Then, probably the highest RDA of all the vitamins. Probably highest RDA, recommended daily allowance. How much do we require? We require 30 to 60 milligram per day. Some books have given 70. Who require more? Is given only adult and children. Who require more? The people who are smoker, they require double the amount of normal requirement. They must take at least 100 milligrams per day of vitamin C. Why? Because vitamin C is used as an antioxidant in relation with vitamin E. It has a sparing effect on antioxidant property of vitamin E. Always remember these points. They are very, very important and it will help you to answer many questions. Now, what else vitamin C is required for? You know that vitamin C deficiency causes a disease called scurvy. So, what are the pivotal symptoms of scurvy? There is swollen and inflamed gum and bleeding gums. Vitamin C is important for synthesis of collagen. Most important, vitamin C is important for synthesis of collagen. Collagen is neither synthesized nor it is matured without vitamin C. So, wherever we have a small cut or damage or breach in the cell wall, in the endothelium or in any blood vessel, it cannot be repaired without vitamin C. In case of vitamin C deficiency, which occurs mostly in the long voyages, for people who are going for long sea traveling routes, taking sea traveling routes, they do not get fresh fruits, fresh limes, etc., etc. So, they suffer from vitamin C deficiency. Yeah. So, they show up with the symptoms of bleeding gums. The moment they start taking lemons in their diet regularly, the symptoms is abated, goes off. Clear? So, we will see what other reactions they participate in. We have to remember many reactions for vitamin C. Vitamin C is the only vitamin which comes as a long question from water soluble apart from or in addition to folic acid as enumerate the functions of vitamin C. Enumerate the functions of vitamin C. There you have to mention as many as possible reactions. Starting with, it participates in collagen synthesis, it has antioxidant functions, collagen synthesis, neurotransmitter metabolism, carnitine synthesis, drug and steroid metabolism, tyrosine metabolism. Remember, any metabolic pathway wherever there is hydroxylation is involved, vitamin C might be needed. Hydroxylation involved, vitamin C might be needed. For example, this one, steroid metabolism. There are many steroids which has got hydroxyl groups. So, it is done mostly by vitamin C. What are the other metabolic functions of vitamin C? Some metal ion metabolism requires vitamin C. Which metal ion metabolism? Iron. Iron. Vitamin C keeps the iron in ferric or ferrous state. Ferrous state. It is reducing in nature, so it will reduce ferric to ferrous. The ferrous form of iron is preferred over ferric form for absorption. Antihistaminic reaction. A lemon a day keeps the doctor away, cold away, so just like that. Immune function, they improve the immune function. They are required for wound healing, they are good for cardiovascular disease protection. For what is the function behind? How do you do it? By their antioxidant property, they prevent cardiovascular disease. Diabetes and cataract, these two diseases increases oxidative stress highly. Vitamin C acts against it by reducing oxidative stress. They cannot reduce diabetes, but they reduce the bad effect, ill effects of diabetes. Diabetes itself is not so harmful, but the related diseases of diabetes are very harmful. So, for example, diabetic neuropathy, peripheral neuritis takes place. What is wrong with diabetes? Nothing. Sugar is more, you are passing urine and sugar is going away, that's all. No, problem is this effect will damage the other tissues. Neuropathy, diabetic retinopathy, diabetic nephropathy. Your kidney will be damaged. So, the vitamin C will actually prevent from formation of cataract. Pulmonary function, and they also prevent cancer because oxidative stress leads to cellular damage. If they prevent oxidative stress, They will prevent premature cancer. How do they do it? Just go through, need not to write. It is already written. You have written it along with vitamin E. You need not to write. Just go through it. How do they do it? Because already you have studied this one. Okay. They donate electrons and hydrogen ions. Okay. They chew up the free radicals. They act as a sparing effect on vitamin E. Attack phospholipid protein embedded in the membrane, reactive oxygen species. They do so. They oxidize LDL and red blood cells and they produce these free radicals, hydroxyl radical, superoxide radical, hydrogen peroxide and hyperoxyl radical. All these radicals are taken care by vitamin C or vitamin E. This is a reaction takes place whenever they meet any oxidizing substance. O2 becomes H2O, ascorbate becomes 2GSH becomes GSHG. This is oxidized glutathione, this is reduced glutathione. Enzyme is glutathione dehydrogenase. Which one we require? We require this one. We require this one for reaction. Correct? Now, well, acha, likhe now. Now, so far we have talked all good about vitamin C. And in the beginning of this topic, I have mentioned that there is no excess, ill effect due to excess consumption of water soluble vitamins. But I was not completely correct because there are some reportings by scientists. They have shown, a group of scientists are there who believe if you consume more vitamin C, then it might create problem. How? Due to pro-oxidant character of vitamin C, means they will help in generation of more and more free radicals. How? There are two reactions in our body which are responsible for production of free radicals with iron, Fe atom. Correct? One is Fenton's reaction, another is Haber-Weiss reaction. These two reactions are mostly responsible for production of free radicals in association with iron, free iron. Now, free iron is harmless if it is in ferric form. Free iron is a product formed due to oxidative stress. Increased oxidative stress, increased free iron in the blood. Free iron is harmless in ferric form, but some doctor friend of yours has said, or nutritionist friend, vitamin C is very good for health. It is antioxidant, like in till previous slide. So you started taking vitamin C thrice a day, if not more, because it is very good. Then slowly vitamin C is also a reducing substance in nature. But what will happen? It will keep the ferric iron in ferrous form. The free iron present in the blood plasma will be converted to ferrous form. The ferrous form of iron will trigger this reaction. What is this? Hydroxyl free radical. That means it is generating reactive oxygen species. That means it is called pro-oxidant. So sometimes a question may be asked like this: justify the following statement. Vitamin C is antioxidant and also a pro-oxidant. Both can come together. Any one of this may come alone. So now you should be able to answer at least that when you are writing its antioxidant property, you must mention its sparing effect over vitamin E. Without vitamin E, vitamin C cannot act alone as complete antioxidant. Okay, they have synergistic effect. They both go hand in hand, vitamin E and vitamin C. If you have vitamin C deficiency, then vitamin E requirement will increase. If you have vitamin E deficiency, vitamin C requirement will increase. Correct? Now, next comes pro-oxidant. So, pro-oxidant you must mention that excess of vitamin C in plasma will lead to conversion of ferric ion to ferrous ion, and ferrous ion will trigger Fenton's reaction. লেখা আছে কোথাও? লেখো এখানে লিখে রাখো, এটা হচ্ছে ফেন্টন রিঅ্যাকশন, FENTON apostrophe S, Fenton's reaction, F capital, Fenton's reaction, FENTON, Fenton's reaction. This is Fenton's reaction. Clear? Done? Now, collagen synthesis. Collagen synthesis, there are 3 steps where vitamin C is required. Lysine to and these 3 reactions. The enzyme for first reaction is second enzyme is lysyl oxidase. In all reactions, okay, and common coenzyme is ascorbic acid, which is converted to dehydroascorbate. Clear? Now, these 2 reactions are called post-translational modification. Means after the peptide is synthesized, these changes takes place. It's called post-translational modification. And these 2 are happening in a protein kind of structure, correct? Every third amino acid in collagen fiber is glycine. In 33% cases, X is proline. In 33%, correct? And what type of proline and lysine? Hydroxylated proline and lysine. Hydroxylated proline and lysine. Now, everything has got a this thing. Proline is required for sharp bending of the molecule. Correct? Sharp bending means tightly twisted. Lysine is required for this cross-linking. Two fibers cross-linked within each other so that they can form a network through which blood cells cannot escape and bleeding will stop. Without this network, it will be free like this. So, blood cells can go through it. Bleeding will not stop. The moment you put a network, bleeding will stop. Third one, this glycine is required for the structure for this purpose. At this point, all the three fibers come very close to each other. If it is anything other than glycine, that closeness is not possible. And that proximity is required for tight twisting of the fibers. Okay? So, three elements, three amino acids has got three structural requirement for collagen biosynthesis. So, vitamin C is required for these three reactions in collagen synthesis. So, this question can be asked along with protein, collagen structure. This question can be asked with vitamin, correct? Both. And this question can be asked also with post-translational modification. One answer, three questions. What else can I give you? Yeah? Okay, fine. This one, have you heard of carnitine ever? No, because carnitine is present in beta oxidation pathway of fatty acid. Carnitine is required for carrying purposes. Acyl group across mitochondrial membrane. Acyl group across mitochondrial membrane. This carnitine is a specialized product formed from lysine. এই লাস্ট পরীক্ষাটা হলো এটা এসেছিল, এই কোশ্চেনটাই এসেছিল। কার্নিটিনের সায়েন্টিফিক নেম বলো বা নেম মানে কেমিক্যাল নেম বলো। আচ্ছা যাও, ট্রাইমিথাইল লাইসিন একটা ইন্টারমিডিয়েট, সেখান থেকে লাস্ট স্টেপে 3 হাইড্রক্সি ট্রাইমিথাইল লাইসিন তৈরি হচ্ছে। এই যে স্টেপটা আলফা গ্লুটারেট থেকে সাকসিনেট আর CO2 বেরিয়ে যাচ্ছে আর লাইসিল হাইড্রক্সিলেজ দিয়ে একটা হাইড্রক্সিলেশন হচ্ছে, সেম রিয়াকশন, লাইসিল হাইড্রক্সিলেজ সেম রিয়াকশন, বাট দিস ইজ টেকিং প্লেস হিয়ার উইথ ট্রাইমিথাইল লাইসিন মিনস মডিফাইড লাইসিন, and this will give rise to carnitine, this function of vitamin C in carnitine synthesis. একটা রিয়াকশন খালি মনে রাখবে এখানে, যদি নামটা মনে নাও রাখতে পারো চলবে, ইজ নট রিকোয়ার্ড, জাস্ট অ্যাটলিস্ট ইউ মাস্ট মেনশন ইন কার্নিটিন বায়োসিনথেটিক পাথওয়ে ভিটামিন সি ইজ রিকোয়ার্ড। এই রিয়াকশনটা অতটা মনে না রাখলেও চলবে। আমার ক্লিয়ার? দরকার নেই, এগুলো দরকার নেই। চলে আসি টাইরোসিনে। টাইরোসিন মেটাবলিজম আগে উপরটা লিখে নাও এইটা, ঠিক আছে? এখানে তিনটি জিনিস আছে, দেখো তিনখানা রিয়াকশন আছে। প্রথমটা হচ্ছে ফিনাইল অ্যালানিন হাইড্রক্সিলেজ টাইরোসিন মেটাবলিজম। ফিনাইল অ্যান্ড টাইরোসিন মেটাবলিজম একই সঙ্গে হয়, দে শেয়ার কমন ক্যাটাবলিক পাথওয়ে, ফিনাইলিন অ্যান্ড টাইরোসিন। এগুলি পড়ানো হবে পরের ক্লাস থেকে। ফিনাইলিন টাইরোসিন বাই ফিনাইলিন হাইড্রক্সিলেজ, সেখানে কিন্তু ভিটামিন সি লাগে না, সেখানে কি লাগে দেখো, একটা নতুন ধরনের কম্পাউন্ড লাগে টেট্রাহাইড্রোবায়োপ্রিন। আমি পড়াচ্ছি না কারণ এটা পরে পড়ানো হবে। টাইরোসিন থেকে ডোপা, টাইরোসিন থেকে PHPP প্যারাহাইড্রক্সি ফিনাইল পাইরুভেট, এই দুটো স্টেপে দেখো এখানে ভিটামিন সি লাগবে, এই যে কোথায় গেল, টাইরোসিন থেকে টাইরোসিনেস তো কোথায় গেল, এইটা সরি, না টাইরোসিনেসটা কোথায় গেল, টাইরোসিনেস রিয়াকশনটা, টাইরোসিনেস রিয়াকশনটা পরে আছে বলে যা দেখছি না, এখানে নেই, এখানে আছে দুটো, এটা ডোপামিন থেকে নরএপিনেফ্রিন একটা সিনথেসিস আছে, নিউরোট্রান্সমিটার ডোপামিন, এপিনেফ্রিন, নরএপিনেফ্রিন, এই তিনটে প্রোডাক্টকে বলা হয় ক্যাটেকোলামাইন্স, ঠিক আছে। এর সিনথেসিসের জন্য ভিটামিন সি লাগে, যেখানে হাইড্রক্সিলেশন হচ্ছে ডোপামিন থেকে নরএপিনেফ্রিনে। ডোপা ডিকার্বক্সিলেজ গেল তো, প্যারাহাইড্রক্সিফিনাইল পাইরুভেট থেকে হোমোজেন্টিসেট পিএইচপিপি অক্সিডেজ, এই স্টেপটা ভিটামিন সি দেখো, অ্যাসকর্বেট থেকে ডিহাইড্রো অ্যাসকর্বেট হলো। পরের স্টেপ হোমোজেন্টিসেট অক্সিডেজ, এই স্টেপটা পিএইচপিপি হাইড্রক্সিলেজ, 4-মেলাইল অ্যাসিডের তৈরি হচ্ছে, এখানে অ্যাসকর্বিক অ্যাসিড লাগছে। এই রিয়াকশনটা না হলে এইখানে যদি ব্লক হয়, একটা অসুখ হয়, তাকে বলা হয় কি অ্যালক্যাপটোনিউরিয়া, টাইরোসিনের সময় পড়বে। এবার এভরি স্টেপ ইন ক্যাটাবলিক পাথওয়ে অফ টাইরোসিন দের ইজ এ ডিজিজ। তাহলে অ্যাটলিস্ট এই রিয়াকশনগুলো মনে রাখো, একটা হচ্ছে প্যারাহাইড্রোক্সিফিনাইল পিএইচপিপি অক্সিডেজ, আর একটা হচ্ছে হোমোজেন্টিসেট অক্সিডেজ, পিএইচপিপি অক্সিডেজ আর হোমোজেন্টিসেট অক্সিডেজ। এখানে হচ্ছে নরএপিনেফ্রিন ডোপামিন হাইড্রক্সিলেজ, আর আসো এখানটায়। নেক্সট অ্যানাদার নিউরোট্রান্সমিটার, serotonin biosynthetic pathway requires vitamin C from tryptophan, serotonin biosynthetic pathway লিখে রাখ, ছোট ছোট করে লিখে রাখ, সেরোটোনিন বায়োসিনথেসিস, ডোপামিন থেকে নরএপিনেফ্রিন, এই স্টেপগুলো লিখে রাখ। এগুলি সব পড়বে, এগুলি সব পড়ানো হবে along with amylase metabolism। রিয়াকশনের নামগুলো এখন জাস্ট লিখে রাখো টু এনিউমারেট। Okay, so this reaction is dependent on vitamin C for regeneration of tetrahydrobiopterin, serotonin biosynthesis. আগে লেখা আছে এটা হয়নি, লিখে নাও, করে বলবে যদি আগেরটা যদি দরকার আমি করে দেবো, আগেরটা যদি অসুবিধা হয়। জাস্ট একটু রিক্যাপ করি, ভিটামিন সি, ফাংশনস অফ ভিটামিন সি যদি আমি বলি তাহলে কি কি বলবে? নাম্বার 1, অ্যান্টিঅক্সিডেন্ট প্রপার্টি, sparing effect on vitamin E. Number 2 is scavenging or chain breaking. Scavenging or chain breaking? Scavenging. Number 2, collagen biosynthesis. Number 3, immune system. Number 4, antihistaminic, correct, antihistaminic function. Number 5, tyrosine catabolic pathway. Number 6, serotonin biosynthesis pathway. Number 7, steroidogenesis. Number 8, okay, right, cataract prevention, ঠিক আছে। আচ্ছা, তাহলে মোটামুটি more or less at least you must write 7 to 8 functions of vitamin C if it comes as a long note, and any 2 or 3 point you must elaborate. Then you will get good marks. Any 2 or 3 points. Okay. That's all for water soluble vitamin. Now comes the overall important questions from this chapter. Write down long question. Long question. Along with clinical manifestation. মানে ক্লিনিক্যাল কেস দিয়ে আসতে পারে। ভিটামিন এ পাশে লেখো, রাইট ডাউন নাইট ব্লাইন্ডনেস। ভিটামিন ডি পাশে লেখো রিকেটস, অস্টিওম্যালেশিয়া। ক্লিনিক্যাল কেসগুলো এরকম হবে যে একটা সাপোজ a boy of 8-year-old boy comes with this and this, what is your provision diagnosis? It is ricket due to vitamin D deficiency. Okay. Then functions of vitamin C. 1 carbon metabolism. এবার শর্ট কোশ্চেন। শর্ট কোশ্চেনে প্লেনটি জিজ্ঞেস করতে পারে, কিন্তু এখানে আসবে হচ্ছে ফাংশনস অফ ভিটামিন ই, ভিটামিন কে সাইকেল, deficiency manifestation of vitamin K, therapeutic use of vitamin E, beriberi, pellagra, B2 deficiency, anemia preventing vitamins. কোশ্চেন আছে কিরকম, enumerate the different vitamins which prevent anemia. কি বলবে, কি ভিটামিন আসবে? B6, folic acid, B12 আর ভিটামিন এ। ঠিক আছে, ভিটামিন এ কেন? টিস্যু ডিফারেন্সিয়েশনে সাহায্য করে। ইট হেল্পস ইন টিস্যু ডিফারেন্সিয়েশন। সিএফইউ, বিএফইউ থেকে সিএফইউ তৈরি হবে না ভিটামিন এ থাকলে। ঠিক আছে, আচ্ছা। ফাংশন ভিটামিন সি বললাম, বেরিবেরি বললাম, পেলেগ্রা বললাম, অ্যানিমিয়া প্রিভেন্টিং ভিটামিনস বললাম। নিয়াসিন বলছি, B6 বলেছি। আচ্ছা, coenzyme function of vitamin K, comma vitamin B12. Coenzyme function of vitamin K, comma vitamin B12. এই হলো মোটামুটি। হ্যাঁ, মোটামুটি এগুলি করলেই হবে। ঠিক আছে, ফর RDA, রিমেম্বার দ্য RDA অফ অল ফ্যাট soluble vitamin. Very easy. You have to remember only which one? Separately, vitamin A. Rest all are almost nearby. The RDA of all fat soluble, water soluble vitamins are almost same, 1.5 to 2 milligram per day, except C. Okay. Okay. Sometimes they ask, like in a vegan diet, person taking vegan diet showing anemia. What is the cause? Vitamin B12 বলতে পারবো। ঠিক আছে, কেন হবে? What is the reason? Folate trap. Due to folate trap. Folic acid is there, but due to B12 deficiency, folic acid is not used. So in deficiency of folic acid কি টাইপের অ্যানিমিয়া হয়? Correct. So you will see megaloblastic anemia. The person will show with megaloblastic anemia. Clear? আচ্ছা আর কি আছে? এই তো মোটামুটি ঠিক আছে, আর কিছু না। You have any question? Anyone? Any queries? যেটুকু আমি পড়িয়েছি, you focus on what I asked you to write down, note down and taught. Whatever I have spoken and asked you to write down, what I asked you to read is for reading purpose only. What I asked you to write down for writing answer purpose only. Very clear. That's all. Thank you.
You have to know there are lots of muscles that are acting on the hip joint. Okay. So tell me at first what type of joint it is? It is a ball and socket type of synovial joint. And most thing is that, tell me one thing, is it a stable? Is it a stable joint? What about the shoulder joint? Unstable joint. So which is stable, that means movement would be limited, but in case of shoulder joint, what you are saying? So there are free movement that is occurring in shoulder joint, right? But it is a unstable joint. That's why dislocation of shoulder joint is very much important. First one. So that is very much important, okay? So at first write it down, what is hip joint? It is a ball and socket type of synovial joint, ball and socket type of multi-axial joint. Main articular processes are one is forming the ball, another one is the socket. So which is the ball over here? It is the head of the femur. And what is the characteristic of head of the femur? It is forming 2/3 of a sphere. Okay, it is forming 2/3 of a sphere, and you know it is covered by the articular cartilage. Okay, it is covered by the articular cartilage, and articular cartilage is a type of hyaline cartilage. Okay, and what about the acetabulum? Is it complete or deficit? Well, so actually it is a semicircular kind of thing, okay, where it is looking like a horseshoe, okay, but where it is deficit at the inferior part, okay. So there is a presence of inferior part, there is a presence of ki thake okhane, very good, that is the transverse acetabular ligament, very much important, okay. So which is forming the deficit part of acetabulum, that is the transverse part of the acetabular ligament, okay. So you could see over here the hip joint is the articulation between the hemispherical head of femoral head. If you keep this to the point, you will get more marks, okay, because whenever it comes as long question, you could mention to the point, okay. What is the feature of the femoral head, okay. How is the acetabular cavity? You are seeing it is a cup shape, okay, or you could say it is a kind of horseshoe shape, okay. So the articular surface of acetabulum is horseshoe shaped and it is deficient inferiorly. So what it is called? That is only the acetabular notch, okay. So what is the definition of acetabular notch? When the acetabulum is deficit inferiorly, that particular irregular part is known as acetabular notch, okay. So acetabular notch also sometime asked in the viva, okay. So at that time you have to know that is the deficient inferior part is the acetabular notch, okay. Now see, this is already I have mentioned, it is a type of synovial joint and it is a ball and socket variety. So acetabulum of the hip, that is pelvic bone, it is making the articular surface, another one is the head of the femur. Okay. So, the lunate surface of the head of the femur except the fovea are converted to the hyaline cartilage. So, these things you have to know. If you have the head of the femur where you do not have the articular cartilage, that is known as fovea capitis. Okay. You have seen the femur, right? The head of the femur has got one depression, that is nothing but fovea capitis. So, at that part it is not covered with the hyaline cartilage. Understood? Okay. So, then the next one is the non-articular acetabular fossa contain loose connective tissue. So, now tell me what is this thing? If you have got the acetabulum where it is, there is no non-articular part, is the acetabulum is completely articulating? The complete acetabular fossa, it is not articulating completely. Downwards inferior part it is not articulating. So, what does it contain? That is the loose connective tissue. Okay. So, you write it down, the content of the non-articular part, the content of the non-articular part of acetabular fossa contains the loose connective tissue, contains the loose connective tissue. Okay. Now, see what is the capsule of hip joint. If you have to elaborate the hip joint, what are the things you have to say? First one you have to say about the hyaline cartilage, okay, articular cartilage. Next thing you have to elaborate the capsule of hip joint. Then next is the acetabular labrum, next is the synovial membrane. So, how many things are there that are present between these two bony part, between the head of the femur and the acetabulum? Understood? So, what is the, write it down, capsule of the hip joint, capsule of hip joint. Okay. So, for capsule of hip joint, it encloses the joint and is attached to the acetabular labrum medially. So, what is the attachment? If somebody will ask, what is the attachment of the capsule of hip joint? Is it throughout it is articulating with the acetabulum? No. Actually, it is articulated with the acetabular labrum. Okay. It is articulated with the acetabular labrum. Where? Medially. Okay. And what about the laterally? You know, it is attached on the anterior aspect of femur between the greater trochanter and lesser trochanter, that is known as intertrochanteric line. Okay. So, medially it is attached to the acetabular labrum and laterally it is attached to the intertrochanteric line of the femur. Okay. So, in front along with the posterior aspect of the neck and the bone behind. So, what about the posterior attachment? This is the medial attachment and lateral attachment. What about the posterior attachment? The whole neck of the femur, and that too, you know, neck of the femur is deficient posteriorly, where? Suppose neck of the femur is 5 centimeter long, right? So, anteriorly it is throughout cover. I told na, a capsule is C shape. So, posteriorly it is deficit, it is only attached to the medial aspect of the neck of the femur. Okay. Lateral aspect of the neck of the femur is empty. Okay. There is no attachment of this capsule. Okay. So, you have to first describe what is hip joint, next one is capsule of hip joint. Okay. Then see what is acetabular labrum. Acetabular labrum means it is C-shaped fibrocartilaginous structure. So, labrum means if you are saying glenoid labrum, okay, if you are saying we will study the knee joint meniscus, that is also kind of fibrocartilage. Okay. So, this is C-shaped fibrocartilaginous collar attached to the margin of acetabulum, throughout the margin. Now, think about the margin of the acetabulum. Okay. So, which thing is that is the acetabular labrum. Okay. And what is the function? If somebody will ask what is the function of acetabular labrum, so it increases the depth of the joint cavity. Okay, it increases the depth of the joint cavity of hip joint. Why? For the better retaining of the head of the femur, right? Whenever we are walking, we are sitting, in every movement, okay, so that time the head has to occupy maximum area of the acetabulum. So at that time this labrum is deepening the cavity, okay, increases the depth, okay. So now coming the synovial membrane. The synovial membrane lines the capsule, covers the portion of the neck of the femur, okay. Now tell me the synovial membrane, right? What is the main function? Which fluid does it secrete? So what is the main content? Hyaluronic acid, okay. So what is the function of the hyaluronic acid? Lubrication, and it also prevent the friction. And there are certain type of incidents when there is concentration of hyaluronic acid is increased. Could you tell some of them? কখন increase হয়? It is related to the lunar cycle. Understood? Whenever there is full moon or no moon, at that time there would be pain in the joint cavity. Why? Because of the friction, because of the gravity. Same like the other fluid. What is happening to the sieve? Right? So same thing is also happening in our joint. Okay. And in osteoarthritis, what is happening? This fluid decreases. Okay. And that's why maximum patient complain there is pain and stiffness at the morning. They will have pain and stiffness at the morning. And main reason is this hyaluronic acid. Okay. So this is this NC, the ligamentum teres femoris. Okay. So synovial membrane, it is the membrane that lines the capsule. It covers a portion of the neck of the femur within the joint capsule. So synovial membrane is intracapsular or extracapsular? It is intracapsular. Always remember, synovial cavity is within the capsule, but there are certain structure which are within the always within the synovial cavity, but it is outside the capsule. Okay, there are certain structure. Could you tell which is the structure? Means intrasynovial but extracapsular. So there are certain structure, okay, we will come across. So NC is the ligamentum teres femoris. So what is the function of this synovial membrane? It will encircle the ligamentum teres femoris. I told what are the other two ligament which is round? Which are the other two round ligament in our body? One is ligamentum teres femoris, another one is ligamentum teres hepatis, present in the liver, another one is ligamentum teres uterus, round ligament of uterus. So these are the three round ligament present in our body. One of them is ligamentum teres femoris. Now tell me which are the structure that are taken by this ligament? This ligament is present where? At the fovea capitis, okay. It is covering that area. So which are the structure that is entering to the femur? Femur has to get its blood supply, right? Which are the two artery? Tell me the branches. So there are the branches is known as acetabular branch. Okay, acetabular branch. One branch is coming from the obturator, another one is coming from the femoral. There are two respective artery. So these are known as acetabular branch of medial and lateral circumflex femoral arteries. Write it down. These are the two arteries which are going through the ligamentum teres femoris. Okay. Acetabular branch of medial and lateral circumflex femoral arteries. Okay. These are the two arteries that are going. So now coming to the ligaments. If you are studying the hip joint, you have to know the ligament and muscle. You have to mention. Okay. So which are the ligament? There are two type of ligament. This one is the extracapsular ligament. Now tell me which capsule they are talking about? The capsule of the hip joint, right? So you have to think, you could remember the attachment of the capsule, right? How it is attached medially to the acetabular labrum, laterally to the intertrochanteric line, and posteriorly to the neck of the femur. So these structures are present outside, right? So which are them? First one is, what are the part of hip bone? There are three parts: ilium, ischium and pubis. So these three part of hip bone having ligaments with the femur, right? So first one would be pubofemoral, next one would be iliofemoral, then next one would be ischiofemoral. But the most important is iliofemoral, and it is known as the ligament of Biglow, okay, Biglow, okay, and this is the strongest ligament of our body. What I told, which is the strongest tendon of our body? The tendocalcaneus, okay, and the longest muscle of our body is the sartorius, okay, but the strongest ligament is iliofemoral. Now if you see the iliofemoral, what are the attachment? Okay, so at first we will discuss the pubofemoral. So write it down, located antero-inferior to the joint. Where it is present? Antero-inferior to the joint. Anteriorly means it is going to the femur, and inferior part means the pubis. Okay, antero-inferior to the joint, and it limits the abduction and lateral rotation. So why these ligaments are there in the joint? Main intention is to make the hip a stable joint. Okay. This is the most largest joint, one of the largest joint of our body. So it needs to be stable. Okay. So first one is limits the abduction and lateral rotation, preventing. Okay. Then next one is iliofemoral. It is Y-shaped, located anterior to the joint. So what I am talking about, suppose it is a Y shape. So it has got how many stem? 3 stem, right? One medial, lateral and inferior. So medial stem attached to, medial and lateral stem attached to ilium, okay, and the inferior stem is attached to the femur, okay. So what is the main function? It is limit the extension. See, what is the main function again and again for the ligaments? To prevent the action, okay, prevent the particular action, okay. So this is limiting the extension of hip joint, okay. Then ischiofemoral ligament located posterior to the joint. It is located posterior to the joint. Ischiofemoral, you know, ischium is present where? Pubis is antero-inferior. What about the ischium? Ischium is posterior-inferior. Ilium, ischium are both are inferior thing, okay, and ilium is antero-superior. Antero-superior. Anteriorly থাকে না, ইলিয়ামটা সামনের দিকে থাকে. So these are the structure. So you are having the ischiofemoral ligament. So it is located posterior to the joint, and it will prevent the medial rotation. It will prevent the medial rotation of the hip joint. So always remember, whenever suppose ligaments of hip joint came in short note, okay, you have to mention the ligament, you have to draw the diagram, and you at first you have to mention what is the main function. All are preventing the action, excessive action you could say. Some kind of action would be taken place, but excessive action would be prevented, okay. Next. Okay, now intracapsular are two, okay. Number one is ligamentum teres femoris, So these are the ligament of the femoral head, and it carries, I already told you the vessels, it carries the two vessels, These are the acetabular branch of medial and lateral circumflex femoral artery. ওকে, এবার এই দুটো ব্রাঞ্চের মধ্যে যদি বলে কোনটা ফিমোরাল আর্টারি কোনটা অপটিউটার আর্টারি ব্রাঞ্চ, হোয়াট ইউ উইল সে? দুটো ব্রাঞ্চ বলেছি না, মিডিয়ান এন্ড ল্যাটারাল সার্কামফ্লেক্স ফিমোরাল আর্টারিজ। ওকে, মিডিয়াল ইজ আ ব্রাঞ্চ অফ, মিডিয়ালি কে থাকে? অপটিউটার আর্টারি থাকে। ওকে, ল্যাটারালি কে থাকে? ফিমোরাল। জাস্ট রাইট ইট ইন দ্য ব্র্যাকেট, মিডিয়াল ইজ আ ব্রাঞ্চ অফ দি অবটুরেটর, medial is a branch of the obturator artery, whereas lateral is a branch of femoral artery. Okay, so next one is another most important ligament, that is transverse acetabular ligament. Okay, transverse acetabular ligament. What is this? This is formed by the acetabular labrum. Okay, and as it bridges the acetabular notch, and this notch is somewhat deficit because it is horseshoe, so it is converted to foramen by this ligament. Okay, so write it down, the acetabular notch is converted to, the acetabular notch is converted to acetabular foramen, converted to acetabular foramen by transverse acetabular ligament, by transverse acetabular ligament. Okay, so that's why it is making a complete thing. Okay, and why this foramen is forming? There are numerous vessels that used to pass, okay, through this foramen. So these are the example. What I am asking repeatedly, they have asked, tell me which are the ligament of hip joint which is intracapsular but extra synovial. What I told, synovial cavity would be interior, capsule would be outside. Okay, so there should be some structure which is extra synovial but intracapsular. कुछ structure हो सकता है ना, that is outside the synovial cavity. Okay, so these two are the example. Numerous time it has asked on MCQs. Okay, so these two ligaments are the intracapsular but extra synovial. Okay, এটা এরকম শোল্ডার জয়েন্টে বলতে পারবি, shoulder joint, in shoulder joint already upper limb has completed, so which structure is extra capsular but intrasynovial, whatever, who will say? Very good, so it is কেন বলতে পারেন না সবাই? it is long head of biceps brachii, tendon of long head of biceps brachii. ওকে, যেটা তোরা অলওয়েজ রিমেম্বার দ্য ইন্টারটিউবাকুলার সালকাসের মধ্যে দিয়ে যায়। ওকে, সো দ্যাট স্ট্রাকচার ইজ দিস ওয়ান, সেম। ওকে, নাও ওয়ান বাই ওয়ান, সো ডু ইউ নো হাউ মেনি মাসেল দ্যাট আর অ্যাক্টিং অন দ্য হিপ জয়েন্ট? as many as 13 muscle, just like the brachial plexus. Okay, as many as 13 muscle, and unfortunately you have to remember all of them. Okay, so first one is, first two you could say, because we won't say these two muscles separately. This is known as iliopsoas. Okay, number one is iliopsoas. So iliopsoas origin is from, first we are saying about the iliacus. Okay, so all you remember the iliac fossa. Iliac fossa, where you have seen the iliacus? On the anterior part. Okay, there is iliac line, so that would be completely occupied by iliacus. Okay, and where it got inserted? At the lesser trochanter. These two muscle together, origin is different. Okay, what about the next one? That is the psoas major. So psoas major, how to remember psoas major? See, it is coming from the T12, body of the T12, thoracic vertebra. Okay, and it is going up to where? Up to the L5, up to the lumbar vertebra 5. Okay, and where does it got inserted? That is nothing but the lesser trochanter, these two muscle. Okay, so what about the nerve supply? Both are supplied by, দুটো কি এক? psoas major টা হবে না, because psoas major, see, it is coming only L2 L3, L4 টা নিচ্ছে না। ঠিক আছে, iliacus you could say. Okay, iliacus is the femoral nerve, that is L2, 3, 4, but the psoas major is coming from L2 and L3. L2 and L3. Okay. This is also covering the all over the muscle present on throughout the hip joint. ঠিক আছে, এই 13 muscle পড়লে enough. One by one region you have to study all the thigh, even including the gluteal region. What are the muscles present? You have to know. Okay. So this is about the iliopsoas. Then next one is, so see, this is the picture. Okay. So for psoas major and psoas minor. So already I told what are the muscle present on the posterior abdominal wall. Ki muscle ache amader? 4 muscle, right? Ki ache posteriorly? Diaphragm, first one. Then next one is quadratus lumborum, transversus abdominis and psoas major. ঠিক আছে, মানে psoas major also considered one of the muscle of the posterior abdominal wall. ঠিক আছে, so in the, if you see the psoas major, see how thick the belly are coming. Okay, কতগুলো আছে তাহলে বলতে পারবি psoas major কতগুলো থেকে অরিজিন নিচ্ছে? T12 থেকে নিচ্ছে, L1, L2, L3, L4, L5. ঠিক আছে, মানে 6টা বেলি থেকে অরিজিন নিচ্ছে psoas major, and see the psoas minor, one small one that is coming from the T12 and L1. Okay. Then what about the, this is the iliacus. Okay. So you could see just below the iliac crest you are having the iliacus, and where does it was inserted? That is the lesser trochanter. Okay, lesser trochanter of the femur. Could you tell me the greater trochanter muscle? If you could remember, which are the muscle? Gluteus minimus, gluteus medius, আর ওখানে কি আছে? trochanteric fossa, যেখানে কি insert করে? piriformis. Okay, so these are the muscle. Okay. Then next one is rectus femoris. প্রথমে anteriorly muscle গুলো কভার করছি, ঠিক আছে? So next which muscle is coming? rectus femoris. So rectus femoris origin কে বলবে? দুটো হেড থাকে জানিস তোরা, একটা হচ্ছে লং হেড আর একটা হচ্ছে শর্ট হেড। তাহলে এটা কোন হেডের কথা বলছে? one is reflected head, another one is straight head. তো straight head এটা কোন হেড? straight head, তাই তো? reflected হেডটা কোথায় হবে? inferior margin of acetabulum, right? So that is the reflected head. So this is the straight head. So write it down. You could also mention this is the straight head of rectus femoris. Straight head of rectus femoris. We have to only know which are the muscle that are acting on the hip joint. Okay. So this is the anterior inferior iliac spine. Anterior superior iliac spine থেকে কে হবে? Number 1 is sartorius, and which is the another ligament? inguinal ligament. এখানে কি থাকবে? anterior inferior iliac spine, একটা হচ্ছে the straight head of rectus femoris along with which ligament? inguinal ligament তো superior টাই, inferior টাই কোন লিগামেন্টটা ছিল? Yeah, that is the iliofemoral ligament. Okay, another one is iliofemoral ligament. So action key, so insertion, all you know, it is inserted on the ligamentum patelli, so that is known as tibial tuberosity. Okay, on the tibia, action is hip flexion and knee extension. So action you have to very well you have to remember. Okay, which muscle is doing which action? So see here, hip flexion, flexion of the hip যদি করে তাহলে কি করবে? extension of the knee joint, counteracting muscle, ঠিক আছে? along with that knee extension. Okay, all of the quadriceps femoris doing the same, flexion of hip and extension of the knee. Okay, nerve supply কি আছে? femoral nerve. It's very easy to remember, femoral nerve. Okay, so this is showing the rectus femoris, straight head. Okay, you could see anterior inferior iliac spine, from that it is going to the tibial tuberosity. Okay, next. So this is, next one is the sartorius. Okay, sartorius having numerous function of the hip joint. So number 1 is anterior superior iliac spine, this thing you know, and it is inserted where? To the tibial part, on the proximal part or the medial part of the tibia. Okay, And action is the combination of hip flexion, abduction, lateral rotation and knee flexion. So here what is the counteracting function with the quadriceps femoris? Just doing the opposite. Okay, because that one is doing what? Hip flexion. What it is doing? It is doing the hip flexion, abduction, lateral rotation. So now tell me one thing, how it is doing the two counteracting movement. One time it is doing flexion of the hip and now it is doing abduction and lateral rotation. Okay, because one time it is acting on the origin, one time it is acting from downwards. ঠিক আছে, কখন ফ্লেকশন হবে? সার্টোরিয়াস কখন ফ্লেকশন হবে? ফ্লেকশন অফ হিপ when it is acting on the tibia. Okay, at that time what will happen? Flexion of the hip joint. But whenever it is acting on the superior side, that is anterior superior iliac spine, it will do what? Lateral rotation and abduction. Okay, abduction of the hip joint. Okay, then nerve supply is again femoral nerve. Okay, so what are the muscles that are only supplied by femoral nerve? কি কি পেলাম এখন অবধি? ইলিয়াকাস একটা পেয়েছি. Okay, we have got sartorius and also the quadriceps femoris. Quadriceps femoris যে কয়েকটা আছে সবকটা is supplied by the femoral nerve. Okay, so this is the sartorius. Okay, so sartorius is coming from where? Anterior superior iliac spine, and where it is inserted on the tibial part of the lower limb. Okay, next one. Now coming the pectineus. Okay, pectineus is what? Superior ramus of pubis. You know the pubis having superior ramus and inferior ramus. So from where? Superior ramus of pubis. Okay, insertion on the pectineal line of femur. Now tell me where you have got pectineal line of femur? Posteriorly where? Which line is continuous as spiral line? Posteriorly you have got greater trochanter, lesser trochanter. That is known as intertrochantaric crest. Okay, this crest is continuous as spiral line. Okay, so you have to see just beside one another line, medially it is there, that is known as pectineal line. You have to just go medially to the spiral line. Okay, so that is the insertion of the pectineus. So that's why both the bone you are having pectineal, one is pectineal line. Okay, pectineal line of the hip bone, that is known as pecten pubis. Okay, and another one is this one, pectineal line of femur. Okay, then insertion is that one, action is hip flexion and adduction. Okay, again these are the same thing, no counterpart, both are same, hip flexion and adduction, both are same. Nerve supply by the femoral nerve. Nerve supply by the femoral nerve. Okay, next one. So see how the pectineus. So could you tell me the origin? So that is the pecten pubis. Okay, that is also superior ramus of the pubis. And insertion that posterior side হচ্ছে, femur এর posterior side, that is pectineal line. Okay, then the next one. What is now we are coming? We are moving to the adductor longus. Up to now, how many muscle we have completed? First one is iliacus and psoas major. Then next one is rectus femoris. Then sartorius, pectineus. So how many? 5. Okay. Now the sixth one is the, we are moving where? To the adductor group. Adductor group is also known as the medial compartment. Okay, so medial compartment, first muscle is the adductor longus. Origin is important, that is pecten pubis. ঠিক আছে, adductor longus এর origin কোথায়? Pecten pubis. Okay, insertion middle third of linea aspera. If you could remember the 12 muscle in the linea aspera. Okay, could you tell which are the 12 muscle? কে বলবি বল? Linea aspera of femur, 12 muscle, no? One is gluteus maximus, then gluteal tuberosity, then আরেকটা জি কি হ্যাঁ gastrocnemius, medial head of gastrocnemius. Then next one is all the vasti, 3 adductor. Then আর কে আছে short head of biceps femoris. আর কতগুলো হলো তিনটে আর এখানে দুটো, তাই তো 8টা, আর 4টে কি কি পেকটিনিয়াস, এইমাত্র দেখলি পেকটিনিয়াল লাইনে পেকটিনিয়াস আর plantaris. Okay, so these are the muscle on the linea aspera. Okay, so action is hip adduction. All the adductor main cause, it's very easy. All the adductor is doing what? Adduction of the hip joint. Okay, so this is hip adduction. Nerve supply is very much important. All the adductor group medial compartment is supplied by the obturator nerve, but root value is the same. Okay, L2, 3, 4, but it is ventral division of primary ventral rami of L2, L3, L4. Okay, this is ventral. Always remember anterior division. ঠিক আছে, obturator nerve, and it is coming through where? Through the obturator foramen. You have seen obturator foramen in the hip bone. Okay, so it is coming from there. Okay, so see, this is the adductor longus. Okay, so how the adductor longus is coming? So pecten pubis. Okay, from that where it is inserting on the linea aspera. Medial side or lateral side? Medial side. যদিও এটা adductor longus, but it would be inserted more medially. ঠিক আছে, more medially first muscle কি পাবো? Adductor longus, and it is also giving a contributing boundary of the femoral triangle. তাই তো? Okay, next one. So next one is adductor brevis. Again origin is from the pubis. Okay, insertion pectineal line and proximal linea aspera. Okay, so nerve supply by obturator nerve, action is hip adduction, is the same. Okay, next one. So what is gracilis? Origin is from the pubis. Okay, insertion on the anterior medial surface of proximal end of tibia. Insertion কিন্তু চেঞ্জ হয়ে গেল। gracilis also muscle of the medial compartment কোথায় গিয়ে ইনসার্ট করছে? at the tibia. Where? Which part? Proximal end of the tibia. Okay, proximal end of tibia. Action is hip adduction. Okay, and nerve supply is again obturator nerve. Okay, so see all the muscle. First one is the psoas major, then you have got the iliacus. This is the adductor group. See how the adductor group are there. So adductor longus, then adductor brevis and gracilis. So which is the most medial one? সবার medially কি আছে? gracilis. Okay, so you write one thing, medial to lateral প্রথমে কাকে পাবে? gracilis. ওকে, এটা ডিসেকশনের সময় হেল্প করে। প্রথমে পাবি গ্রেসিলিস, ওকে, দেন পাবি নেক্সট পাবি অ্যাডাক্টাল ম্যাগনাস। ঠিক আছে, দেখ গ্রেসিলিসের পরেই কাকে পাচ্ছিস? অ্যাডাক্টার ম্যাগনাস, এন্ড ইউ কুড সি ইট ইজ দ্য মোস্ট থিকেস্ট মাসল। ওকে, মোস্ট বিগার মাসল। ওকে, দেন নেক্সট ওয়ান, নেক্সট গ্রুপে কাকে পাবি? অ্যাডাক্টার ব্রেভিস কে পাবি। Okay, and adductor longus would be superior. ঠিক আছে, superficial compartment এ পাবে adductor longus. Okay, so the thing is this, sequence is that gracilis, then adductor magnus, adductor brevis, adductor longus. Okay, these are the 4. Okay, and see, this is the pectineus and piriformis. Okay, so what is the tensor fascia lata? Deep fascia. Okay, move to the next one. So adductor magnus, same ischium and pubis. Adductor magnus কেন? It is a hybrid muscle. ঠিক আছে, adductor magnus এর দুটো পার্ট আছে, একটা হচ্ছে ischial পার্ট আর একটা হচ্ছে obturator পার্ট। ঠিক আছে, or adductor part is a muscle of the medial compartment, whereas ischial part is the part of the hamstring. ঠিক আছে, এবং একে হাইব্রিড মাসেল কেন বলছি, ইট ইজ সাপ্লাইড বাই টু নার্ভ। সো হুইচ আর দ্য টু নার্ভ, একটা হবে অবটুরেটর নার্ভ আর একটা হবে sciatic nerve. ওকে, and insertion is entire linea aspera and adductor tubercle. You have seen the adductor tubercle কোথায় থাকে, adductor tubercle কোথায় থাকে, adductor tubercle above the medial condyle, তাই তো, medial condyle of femur এর একটু above এ কি পাওয়া যায়, adductor tubercle elevation. Okay, so that is the insertion point for adductor magnus, nerve supply by obturator and sciatic nerve. Okay, now coming the gluteus maximus. Okay, so it is from the posterior sacrum and the ilium, both posterior sacrum and the ilium. Okay, insertion কোথায়, posterior femur distal to the greater trochanter and iliotibial band. এটার কিন্তু দুটো আছে, ঠিক আছে, একটা কোথায় যাচ্ছে, to the greater trochanter, and another is one of the component of the iliotibial tract. ঠিক আছে, যদি বলে how the iliotibial tract is formed, একটা হচ্ছে from the gluteus maximum and some fibers coming from the tensor fasciculata. Okay, so that is forming the lateral compartment and one of the strongest compartments, so that is iliotibial tract. Okay, then action is hip extension, hyper extension and lateral rotation. যতগুলো সাইডে, ওকে, lateral সাইডের মুভমেন্ট আছে, hyper extension, okay, then the abduction and lateral rotation, তিনটে would be done by main muscle is the gluteus maximus. Okay, then the next one, to see these are the three muscles. First one is the gluteus maximus, so it would be coming on the superficial compartment, you have to cut, then you will get these two, gluteus medius and gluteus minimus, and see this is the obturator internus. Next one, so gluteus medius কি আছে, from the outer surface of ilium. So if you could remember gluteus medius, the outer surface of ilium means the iliac crest, right, and insertion on the lateral part of the greater trochanter. এটা কেন বলতে পারি না, মিনিমাসটা কোথায় হবে, anterior to the greater trochanter, and lateral এ কে থাকবে, gluteus minimus. Okay, then action is hip abduction. So these gluteal region muscle করছে কি, to the lateral rotation and abduction, শুধু হাইপার এক্সটেনশন কে করছে, gluteus maximus. ওকে, আর নার্ভ সাপ্লাই বাই সুপিরিয়র গ্লুটিয়াল নার্ভ, নার্ভ সাপ্লাইও কিন্তু একটু ডিফারেন্ট আছে, ম্যাক্সিমাসে কে সাপ্লাই করলো, একমাত্র মাসেল হুইচ ইজ সাপ্লাইড বাই ইনফিরিয়র গ্লুটিয়াল নার্ভ, ওকে, দ্যাট ইজ gluteus maximus, বাকি তিনটে কে কে করবে, দিস ইনফিরিয়র গ্লুটিয়াল নার্ভ. ওকে, দেন gluteus minimus, so it is from the lateral part of ilium and inserted the anterior surface of greater trochanter. তাহলে এটা মনে থাকবে, anterior part of greater trochanter কে আসছে, gluteus minimus, lateral part এ কে আসছে, gluteus medius. Okay, and what about the gluteus maximus, একটা পার্ট greater trochanter এ, একটা পার্টে iliotibial tract, দুটো পার্টে ডিভাইড করছে, ঠিক আছে. You have seen this is a bulky muscle, so action is hip abduction and medial rotation. Both medius আর minimus কি করছে, just opposite to the gluteus maximus, তাহলে এটা কি করবে, adduction, আর একটা কি করবে, medial rotation. Okay, nerve supply is superior gluteal nerve. Okay, next one, so just write down the name. What are the other deep rotator? Deep rotator are obturator externus, obturator internus, quadratus femoris, quadratus femoris, piriformis, and gemellus superior and gemellus inferior. Okay, so these are the muscle, these are all the muscle deep rotator, these are also known as deep rotator of hip joint. Okay, ওটা লিখছিল আগেরটা করে দাও. Okay, so you have to mention this. So how many muscles, see over here, you have got 6. So 6 out of 13 you are getting over here. ঠিক আছে, গ্লুটিয়াল গ্রুপে কটা আছে, তিনটে, আর অ্যাডাক্টর গ্রুপে কটা আছে, তিনটে, তাহলে কটা হলো, 6টা. ওকে, So see, you could see this is the piriformis. Okay, so you could see how it is coming from the internal aspect of sacrum and where it inserted. বলতে পারবে কোথায় ইনসার্ট করে? Apex of the greater trochanter. Apex of the greater trochanter. Okay. So I don't want to cloud your brain. So this is all the thing about the ligaments and muscle, and about the clinical anatomy I will discuss on afternoon. Okay. So if the hip joint comes as a long question, you have to say all the thing. Okay. All the related thing you have to specify, the synovial membrane, acetabular labrum, everything, capsule basically, and also the ligaments and muscle. Okay. So if you could not describe all thing, at least mention the name of the muscle. Okay, and the function and movement it is doing. Okay, so that is all about the hip joint. Okay. We have studied just now the acetabular notch. So it will be occurring posterior to the acetabular notch. Okay. Normally, always we have seen shoulder dislocation occurs where? Posterior and where it is weak. Shoulder joint is weak medially, and it is most commonly weak in shoulder. Okay, very much common shoulder dislocation. So it could be also managed at the field only. Okay, but in case of this hip joint, you could see it is most commonly posterior to the notch. Okay, acetabular notch. Then next one is position if suppose dislocation occurs. Okay, so what would be the position of the hip joint? It would be legs, adduction and internal rotation. Okay, so this is the position of the dislocation. This towards the medial side. If towards the medial side. Okay, so common mechanism often have knee to dashboard. Okay, that is occurring while driving. Okay, or in the front seat, somebody has been on the car at that time also. Okay, so that is knee to dashboard during traffic collision. Okay, the next one is sign and symptom. There will be extreme pain, obvious deformity, and unwilling to move any kind of extremity. Extreme pain definitely will occur. Okay, and another thing is that you could means patient also could think the leg is medially rotated. Okay, so by that way they could understand. Okay, so now you see the X-ray. Have you written this one? Okay, so this is about the first one, dislocation of hip joint. Okay, dislocation of hip joint. So next one we will go how the X-ray. So see, this is the normal placement. So what will happen? The head of the femur will come out from the acetabular notch. Okay. Now we go to the X-ray to see what is the appearance of X-ray. Okay. So you could see how the femur is being medial side, internally rotated and adducted. Okay. So if somebody has given you normal X-ray and this hip dislocation, you could easily identify. Okay, that it came out. But see, it is not fractured. Right? There is no fracture line. Okay, so by that way you could identify. Then next one is hip pointer. So do you know what is this? Hip pointer. Hip pointer means anyhow it is a sharp injury. It is not blunt at all. Sharp injury. Whenever the corner of hip is injured by any object. Okay, right? So it is known as hip pointer. So in the suppose if the point of hip, corner of hip is injured, so which muscle would be injured? Any idea? Hip muscle at the corner of hip is anterior superior spine and inferior spine. So in this space you will get sartorius. Okay, and this back is some part of okay, and also another one is so these are the muscles getting injured. Okay, so what will happen in that area? There will be pain and swelling. Okay, pain and swelling. Ecchymosis. So what do you mean by ecchymosis? If you see from outside, you will see there is bluish discoloration. area will be bluish discoloration. It is not loose, but it will appear like that. Okay. So something reddish or blackish discoloration. This is known as cyanosis. Okay. Severe leading to motion palpable hematoma. So there definitely some kind of imbalance in movement, right? And another one is there is motion would be there and there will be palpable hematoma. If you palpate that area at the point of view, you will found that there is kind of swelling. Okay, so this is palpable hematoma. That's why this cyanosis is observed. Okay, this is the deep point. Now you will see this is the part. Okay, so position at the corner of input. Okay, so this is the deep pointer. So see which part is injured on the iliac crest. Okay, so here what about any kind of muscle that will be injured. Okay, now very important, that is writing down piriformis syndrome. So what is piriformis syndrome? So tell me what is the origin of insertion? Origin कहाँ पर होता है? Piriformis I told you, the interior surface of sacrum. Okay, if you are seeing the whole pelvic cavity, interior aspect, there is origin of this piriformis. Okay, and where it does it get inserted? At the apex of intertrochanteric line. Okay, at the apex of intertrochanteric line, or you could say at the apex of greater trochanter, there is the insertion of piriformis. So what is happening? Which structure is there? This muscle fiber is running, that is the piriformis. So which nerve is there? Sciatic. So if there is compression of this piriformis, what will happen? So there will be partial damage. Okay, partial tingling sensation to the sciatic nerve. And you know sciatic nerve root value is L4, L5, L1 or 0. Okay, L4 due to lumbar plexus से नीचे L4, L5 sacral नीचे S1 S2 S3. Okay, so sciatic nerve piriformis pressure on the sciatic nerve due to muscle spasm, and it is very common. It's a very common phenomenon. Okay, and trigger points tightness causing the posterior thigh bone. কোথায় পেনটা হবে? It is looking like a sciatica, but it is limited to thigh. Okay, it is limited. যদি sciatica হয়, there would be throughout involvement of the lower body. Because you know sciatic nerve is division occurring, that is common peroneal and tibial nerve, right? Throughout the whole lower limb will involve. But in this case, we are seeing only the posterior part of the thigh. Okay, posterior part of the thigh. So what are the signs and symptoms? There will be pain, limited restriction of movement will be there, limited or restricted movement, and patient tenderness deep to the gluteus. কোথায় থেকে tenderness থাকবে? Deep to the gluteus. So if the pain has been felt below the gluteus maximus or medius, at that point you will have this piriformis syndrome. Okay, so this is another clinical anatomy. So see, this is what is happening. Okay, so if you see the origin, internal side insertion at the apex of the trochanter, greater trochanter. Okay, so which are the other structures are going to detail? একটা হচ্ছে sciatic nerve, all the roots of sciatic nerve. You could also find one artery which is there. Artery কোথায় যাচ্ছে? It is nothing but the femoral artery. Okay, so below these are the two structures, but main involvement of this nerve, because lots of roots are going, roots of sciatic nerve. Okay, so next one is hip fracture. So next one is hip fracture. We are only talking about the hip zone, right? So which are the places the fracture is occurring? Numerous places. বিভিন্ন জায়গায় হতে পারে। কোথায় কোথায়? Number 1, most frequently occurs the femoral neck. That you know, neck of the femur, the most commonest site of fracture of the neck. Okay, situated. Write it down. The fractured neck femur tends to occur, or neck of the femur is the commonest site of fracture in case of injury. Okay, so what will happen? A direct blow to the lateral hip. If someone having the blow to the lateral side, the first thing would happen fracture in the femur. Okay, আর যেটা পরবর্তী ক্ষেত্রে হয় that is known as osteoporosis. Okay, so above the age of 45, basically in case of women, very common fracture. Okay, and the main reason behind is the osteoporosis. Okay, so what are the signs symptoms? Pain, swelling, and loss of function. The inward leg will appear. So what would be the clinical presentation? Write it down. Clinical presentation of fracture leg femur. How to identify? So the leg would be shortened. Leg would be shortened, number one, and will be externally rotated. Externally rotated. That means laterally rotated. Okay, this would be the finding. Okay, if you see the bedside patient, you don't know, you have not found the X-ray, you could have the diagnosis that is the actually. Okay, so shorted and laterally rotated. Okay, so see, these are the part where the fracture will occur. Okay, প্রথমে কি part আছে? This is the intracapsular pin fracture. It is not displaced. So because you know capsule would be interdocumentary line, so it is intracapsular. Then next one, this is fracture leg femur. Okay, so you write it down. Fracture leg femur will be always intracapsular. Fracture leg femur will be always intracapsular. Okay, কারণ আমরা জানি কি capsular attachment to the interdocumentary line at the anterior surface. Okay, then extra capsular legs where the trochanteric fracture. Okay, so that would be through the trochanteric line. যেখানে greater trochanter lesser trochanter meet করছে, so that is the trochanteric line. It is also known as trochanteric fracture. Okay, then another one is extracapsular but subtrochanteric, just below the trochanter. You could find that is the lesser trochanter, so just a little bit below. So it is known as subtrochanteric fracture. So these are the main three hip bone fracture. Okay, write it down. These are the three fracture: fracture leg femur, then intertrochanteric fracture, subtrochanteric fracture. Okay, so all are you to see, all are non-displaced. একটা কিন্তু displaced হয়নি. Okay, why? What is the reason behind? Because of ligaments. Okay, now subtrochanteric fracture also could be displaced, but anyhow there are, you know how the thigh is covered whole by the ligaments muscle. Okay, muscle tendons are going throughout, right? Now the ligamentum patagium would be quadriceps nucleus, it is inserted in the patagium. Okay, posteriorly the hamstring. Okay, so somehow it is protected. Okay, so next one is what is trochanteric bursitis. So you know we are having so many bursa below the trochanter. So which are the trochanteric bursa? কোন muscle আছে trochanteric bursa? Greater trochanter এ anteriorly gluteus minimus, তাহলে bursa of the gluteus minimus. Lateral side কি আছে? Gluteus medius, bursa of the gluteus medius, and what about the gluteus maximus? Posteriorly attached by কোথায়? Gluteal tuberosity, যেজন্য এটাকে আমরা বলি কি থার্ড trochanter, রাইট? তো সেখানে আমরা পাবো bursa of the gluteus maximus. বুঝতে পারলে তাহলে anteriorly কি আছে? Gluteus minimus, laterally কি আছে? Gluteus medius, posteriorly কি আছে? Gluteus maximus. So just below the muscle to prevent the friction we are having the bursa. Okay, so suppose if there is any kind of inflammation to the bursa, so that is the occurrence of bursa. So what will happen? All the abnormal friction or irritation of the bursa between the iliotibial band and another one is greater trochanter. Greater trochanter বুঝতে পারছেন minimus আর medius এর জন্য, আর iliotibial band কি যাচ্ছে gluteus maximus, some fibers are going. Okay, so এই দুটো জায়গায় mainly trochanteric bursa bursa. Another one is very much important, that is known as ischial bursitis. Okay, so what I told, if suppose all of you are sitting, how it has been transmitted. You know how the weight of individual is transmitted in sitting position? Ischial tuberosity. Okay, where is the origin of all hamstring? Ischial tuberosity. So at the ischial tuberosity, origin of all hamstring means semimembranous, semidendrinous, elongated bicep tuberous and ischial fibers of adapted members. So below that you are having again the bursa. Okay, so these bursitis is very much common. Who are sitting for prolonged period, for them it is very common. Okay, so same the feature would be same. Okay, just like how you got all the features for tropinary bursitis. Just remember these are the two type of bursitis. ठीक है, एक तो tropinary bursitis, another one is the ischial bursitis. So see, this is the ischial. Now I have to find it out which one is the ischial tuberosity. It is a comma shaped area. Okay, so the find it out. See the area. Okay, that side is the median is the pubis. So laterally and inferiorly we are having ischial. Okay, so at the corner point, that is known as ischial. Okay, so below you are having the ischiopubial bursa. Then also the pubial bursa. Now next one is avulsion fracture. So what you mean the avulsion fracture? Avulsion means if anyhow during tearing injury, if the muscle fibers or tendon is coming out, so that is known as avulsion. Okay, but here what is happening? Result from a violent contraction or traction of the attaching muscle, whatever muscle. Okay, but it should be related to the hip bone. Okay, so common site is very much important. Where the avulsive fracture used to take place. Okay, so first one is anterior superior iliac spine, sartorius vertebra. ठीक है, then next one is the anterior inferior iliac spine, basal trochanter and ischial tuberosity. ठीक है, এই চারটে হচ্ছে avulsion fracture লোকেশন। ওকে, সাইন সিম্পটম কি হবে? কমপ্লেন অফ সাডেন শার্প পেইন এট দ্য টাইম অফ ইনজুরি ইজ ভেরি কমন। যখন avulsionটা হলো তখন একটা সাডেন শার্প পেইন। ওকে, unwilling to move the extremity, patient tenderness along the bone and may have muscle bulging away from the attachment and spine. Suppose the muscle has been bulged out or there is avulsive injury, what will happen to that area? There will be swelling. Okay, there will be tenderness, it's very common muscle fiber. So this is known as avulsion fracture. Okay, so remember this is nothing related to the bone. Bone কিন্তু কিছু হবে না, right? যতটুকু হবে muscle fibers has been taken out. Okay, so that is avulsion fracture. So see, okay, how the different fibers of muscle has been torn up. Okay, so this is avulsion fracture. So separation ki dekhachhe, separation of the abdominal muscle from the iliac muscle. So when this abdominal muscle ki ache, that is also related to the hip bone, right? Ki ache, abdominal muscle insertion hoya ki further origin hai. Iliac crest ta mone korbo, iliac crest. কোনটা ইনসারশন হবে, কোনটা অরিজিন? ইন্টারনাল অবলিক আর ট্রান্সভার্স অরিজিন, ঠিক আছে, আর এক্সটারনাল অবলিকটা ঠিক আছে। তাহলে এই পার্টটা অ্যাভালশন হতে পারে, আর কি হতে পারে? আর এটা হচ্ছে এখানে যেটা দেখিয়েছে which one, this is nothing but the sartorius. Okay, part of the upper part of the sartorius. ঠিক আছে, so this one is another one that is known as Barthes disease. Okay, Barthes disease, another name is late calf. Exactly spelling ka jeta se dekho, late calf or Barthes disease. What is that? It is mainly occurring in children. Okay, what is the reason behind it? Because the fovea cavities, in that you know which are the blood vessels morning I told, these are going. So the vascular supply to that head of the femur is not sufficient. Okay, so resulting কি হবে? males than females. This is also important one. Okay, more common in male children than female, and sign and symptom feel at the tip of groin. ठीक है? Main thing is that it will be radiating to the knee. Okay, and there will be limping. Children could not say, they could not hardly connect to you. What they will do this? Basically, they could also show you the location that in or something like that. So, what is happening? Rather than that, there will be limping. Okay, decreased restriction of movement, and there will be heat pressure tightness by the physician. Okay, so these are the main thing you have to know. This is nothing but the avascular necrosis of the neck of the femur, but in case of children. Okay, causing the damage of the proximal epiphysis of femur. Okay, so now we see the picture. So see, this is what is happening. See how so many blood supply the neck and head is getting. Okay, so you could see there are chain of run. First one is run of operator artery. Okay, lateral and medial circumflex femoral arteries. Good. Okay, so it is making one anastomosis network. Okay, so this thing is hindered. So finally, what is happening? Okay. The next one is fracture neck femur. It clinically you have to study very nicely. What is fracture neck femur and what are the different types? Okay, so it is common in age group of 60 to 80. Okay, 60 to 80. But always not happening to the elderly. Sometimes it also happens to young adults and even the children. Okay, and again it is more common in women. Okay, মোটামুটি 45-50 age group women এসেছে and having this thing I told what are the features, there will be leg will be shorted and laterally rotated. Okay, this is the findings you will get from the patient. Okay, so you also diagnose it is nothing but fracture. Okay, so the fracture may result either from rotation of violence at the hip due to tripping over something on the floor. Maximum যেটা করে হয় যে স্লিপ করে গেছে, right? So that is the main reason. Rather than that, any kind of direct violence of the right? So these are the two reasons the person having fracture neck femur. Okay. So these are the key points. Age group of what is elderly 60 to 80. ঠিক আছে? আর যদি women হয় it is above 45 যখন osteoporosis হয় তখন. So what are the type of fracture? It is fracture neck femur টা হয় these are two types. Write it down. One is intracapsular and one is extracapsular. Intracapsular দেখতে নিচ্ছিস maximum কি হবে intracapsular. So see intracapsular. Now intracapsular is subdivided again into কতগুলোতে ভাগ হয়ে যায়? Number 1 is subcapital. Subcapital মানে what do you mean by subcapital? Caput means what? Okay? So just below the head. Number 1 is just below the head. Next one is transcervical. This means cervix means neck. Whenever cervical vertebra, that means neck, right? So transcervical means it is going to the neck of the femur. Then the third one is the basal at the junction of the neck and shaft. Okay, below. So this is there are three type of fracture neck femur intracapsular. ठीक है? So see, these are the three types. Right? So both of them just below the head. Okay, so that is subcapital. Then we are having the transcervical. Then just below that there will be this one basal. Okay, below the neck. Now extracapsular. Extracapsular are also very much important. Okay, fracture from the base of the neck to the pre-trochanteric region. Okay, and there are all the groups of trochanteric fracture. Also these are considered as trochanteric fracture. Write it down. Extracapsular fracture are actually the trochanteric fracture. All are considered as trochanteric fracture. Okay, so in that also we are having numerous grade. What are the grade we are having? We are having four grade. Grade 1, grade 2, grade 3, grade 4. Okay, so grade 1 की incomplete fracture at a neck, so called abduction or impact. Okay, incomplete. So first one is incomplete. You just write one grade 1 incomplete. Okay, grade 2 माने कि complete fracture without displacement. Grade 3 माने कि complete fracture there will be partial displacement. And last term माने कि there will be complete fracture and partial displacement. Okay, so these are the four grades. Number 1 is incomplete. So incomplete means what? What do you mean by incomplete? Fracture नहीं होचे, तब भी capsule is intact. ऐसा नहीं है. So you need to just fix that bone. Okay. So this is the first one, grade 1. Then grade 2, grade 3, grade 4. And मने था कि ओइटार तो तीन भाग intracapsular and this one is having four division. Okay. So see these are the four. First one see the fracture का वही अच्छा. Right. Then next one का complete হয়ে গেছে তো ডিসপ্লেসমেন্ট আরটা কি হচ্ছে কমপ্লিট হচ্ছে পার্শিয়াল ফোরটা কি হচ্ছে কমপ্লিট হয়েছে এন্ড কমপ্লিট ওকে এটা কিন্তু শর্ট নোট বা লং কোশ্চেন টাইপের আসতে পারে ওকে দিস ইজ নট ইওর টপিক ফর ক্লিনিক্যাল অ্যানাটমি সো ক্লিনিক্যাল পিকচার কিভাবে ইউনিট টু ওয়ার্ক অলরেডি আই টোল্ড ইউ এক্সটার্নাল রোটেশন এন্ড শর্টেন অফ দি limb okay and the attachment of the capsule distal fragment prevent excessive external rotation of the limb যদি তার ক্যাপসুলটা থাকে সেক্ষেত্রে এক্সটার্নাল রোটেশন উইল বি প্রিভেন্টেড নট কমপ্লিটলি রোটেটেড ওকে দেন অন palpation so how to identify that is a fracture link you have not done any kind of x-ray तो ये बोलते हैं पेशेंट को तो रोटेट टेस्ट पार्ट you have to answer so anyhow you want to make some kind of background first you can fracture link how do you identify you will palpate that area কোন এরিয়াতে ইনফেকশন দেখা যাচ্ছে গ্রেটার টোন ঠিক আছে গ্রেটার টোনটার মধ্যে কি থাকবে হেডটা ল্যাটারালি আছে রাইট টোনটা মিডিয়ালি থাকবে রাইট সো দ্যাট এরিয়া ইউ উইল সি देयर will be indication ওকে সো দ্যাট ইজ দ্য ডায়াগনোসিস ফর দিস ফ্র্যাকচার নেক and all type of movements are extremely painful. Okay, all type of movements are extremely painful. Now another topic is hip replacement. Okay, so hip replacement is all you know. It is an artificial thing, right? We are replacing the part of the articulating hip, right? So we may replace the head of the femur as well as we may replace the aspect, or we may replace the bone. ठीक है? So here, what is the definition in hip replacement? It is a common type of surgery where a damaged hip joint is replaced with the artificial one. Okay. Then it is common often 60 to 80. Okay. Then more also may encounter with younger ages. Doesn't matter. But modern artificial hip joint is designed to last up to 15 years. Although নিচে বলেন so that is 15 years. Okay. So this is the hip replacement. Most people have a significant reduction in pain and improvement in the range of movement. Okay. So first one is reduction of pain. Then the range of movement is also more. Okay. So they ensure this thing about the hip replacement. So indication when does we replace the hip? What are the indications? Okay, there are some certain issues. Number one, severe hip pain while resting or pain limits the daily activity. Daily activity, walking, sitting, running, whatever, is not able to do. So that is number one cause. Then a hip fracture that did not heal properly. Suppose a hip fracture এখন বললাম অবস্থা it does not heal properly. সেটা একটা ইন্ডিকেশন হতে পারে. Then the third one is hip inflammation and swelling that does not improve with rest or medication. If you are providing any kind of rest or medication, but still it is not improving. Okay, তখন বলতে পারো hip replacement. Then no improvement with medication, cortisone injection. Cortisone steroid is very much used in this case. Okay, to reduce the pain. So cortisone dio, there is no alleviation of pain. Okay, so in that case we will do this thing. And another one is physical therapy or any other kind of surgery. Okay, so these are the indications of hip replacement. Hip replacement, he first you have to mention all the points. Okay, at first the procedure, then next you have to mention the indication. Okay, so procedure is, so we will just choose any kind of anesthesia, maybe general anesthesia, maybe epidural anesthesia, whatever. Okay, and another type of anesthesia is spinal anesthesia. That you know what will happen. Below the waist there will be anesthesia. Okay, below the waist. So that is the spinal anesthesia. And epidural anesthesia there will be less pain. Okay. So incision কত দেওয়া হবে? Up to 30 centimeter over the side of your hip. Okay, this is very much basic. Just you know the procedure. So what will happen? At first upper part of femur is removed. যে এরিয়াটা upper part of femur has been damaged, that is removed. Okay, then what we are doing, socket for the femur, that is hollowed out. Okay, the socket is fitted with the hollow of the pelvis. Okay, then finally there is kind of cement they used to call, they will put over there and they will fix the pelvis. Okay, they also may insert the steel. Okay, the operation used to take place 2 hours. So see, this is the procedure. Okay, so প্রথমে you could see that damaged femur. Okay, so they have taken up, they have just parted and moved. Okay, then that area is replaced by this artery. Okay, so this is the hip replacement. Okay, another procedure is, see, minimally invasive surgery. In this case only you are doing 1 centimeter incision. ওখানে কত হচ্ছে 30 centimeter. ঠিক আছে, and it is very much less painful after the operation. So that's why you are choosing. যে কারণে আমরা ল্যাপারোস্কোপি চুজ করি, তাই তো, এখন ওপেন সার্জারি করি। So this is another one. So this is the procedure. So what is happening previously, how the hip and afterwards. Okay, this is the replacement. Okay, so this is the replacement. Next one. Complication কি আছে? Suppose hip replacement has been done. So which are the complications may arise? Okay, number 1 is infection. Infection of hip replacement, that is 1% of patient is kind of heart attack, stroke will happen. Okay, another most important thing is, write it down, most important complication is blood clot. ঠিক আছে, blood clot, I already told you blood clot correct, right? So in that case some kind of embolism will occur, pulmonary embolism. Okay, and what will happen, suppose blood clot has happened, so you have to use the blood thinners. ठीक है, a damage to the nerves and vessels over the hip, and this is the rare occurrence of the distribution of hip. ठीक है, so hip replacement, clinical anatomy of hip joint, and another one is fracture link femur. These two are very much important. Okay, in topic, one is fracture link femur